So thank you, Dr. Vikram Talaulikar, for doing this. So I thought, why not have a topic that combines the both very important topics together, which is breast cancer risk and HRT.
Thank you, Hajra. Thank you for doing this. Yes, my day has started well. Looking forward to the week.
Just a quick introduction. So this is Dr. Vikram Talaulikar, an associate professor from the UCLH. And you have your own menopause clinic. I think it's called the Luna Clinic.
Yes, there are a couple of places, the Luna and the 10 Harley Street. Correct.
Yes, that's right. But more importantly, you are heavily involved in all the menopause-related research. And I came across your first talk, which was on musculoskeletal health and menopause. So we both know how menopause affects women in all fronts in terms of symptoms, but also the long-term health. But one particular controversial area is breast cancer risk, particularly when we're having the discussions of starting HRT. So I thought this is something that we really need to address because it's highly contentious. It causes a lot of worry for a lot of women because they either know someone who's had breast cancer or they've got family members. So I don't know if we can debunk things today, but just to provide a little bit of clarity for clinicians as well as patients in trying to understand this risk. So my first question really is, how are the sort of HRT products affecting breast cancer risk? Because we know that combined HRT has a slightly increased risk as compared to estrogen-only HRT. So if you can just shed some light into that topic.
And I know, Hajra, you've done lots of this on social media as well. You've done an infographic, isn't it? So that's useful. You're right. Breast cancer still remains one of the major concerns, both for women who want to access HRT. They're worried, will I get breast cancer because of HRT? But equally, health professionals tend to hesitate prescribing if they feel somebody's risk of breast cancer is higher. Because at the end of the day, no one wants to hear the word breast cancer. Everybody is worried about it. HRT per se does come as a risk factor for breast cancer. And as you rightly said, it depends on what type of HRT, what is the combination, what is the actual product you're using. But generally, as we know now, when we say HRT, we are talking about giving estrogen and a form of progesterone or progestogen, which we combine for most women. And women will take this HRT to relieve their menopause symptoms for a certain period of time. Now, all the evidence that we have so far suggests if a woman takes only estrogen, that means she's had a hysterectomy, she doesn't have endometriosis, and she's only taking estrogen because she doesn't need the progestogen, it has very little or minimal impact on the risk of future breast cancer. And we know that from two things. One is there were big studies like WHI, which are sort of randomized gold standard studies, which happened 20 years ago, and women have been followed up for 20 years. And women who were taking estrogen only do not seem to have any excess risk of breast cancer. In fact, as you have put it in your infographic, they have lower risk of breast cancer. But if you look at combination HRT, which means you combine an estrogen product with a progestogen, and again, you could argue which progesterone, which progestogen, but let's take it as an umbrella term, a progestogen combined with estrogen. So this is for majority of women who will still have a uterus. They need protection of uterine lining from progestogen. There is a small increased risk of breast cancer. And it's usually one woman per 1,000 women taking HRT every year. So if you look at 5 years, it will be 4 to 5 extra women in 1,000 women taking HRT over 5 years or so. So the difference actually is very little. The actual risk is about maybe 1 or less than 1 in 1,000 women every year. It's made to sound big many a times, but nevertheless, a woman may still say that's an unacceptable risk for me. And that's why we say combined HRT increases the risk, estrogen unlikely to increase the risk on its own.
And also, I think you rightly mentioned, you mentioned absolute numbers, because when we compare that with relative risk, that also seems a lot more sort of exaggerated, or I don't want to say exaggerated, but quite heightened. And
That's
again,
right.
you know, exactly. So that would cause a bit more concern when you say it's double the risk as opposed to when we're mentioning the absolute numbers?
And that's what happens in media. Often you read the media headlines, you read newspaper headlines, you read articles, and they will say, oh, the risk has doubled. But what is doubling of risk? 1 in 1,000 goes to 2 in 1,000. That's still less than 0.5% risk overall. That means 999 out of 1,000 women will not have that risk. It's 2 in 1,000 as compared to 1 in 1,000 with something. But when you say it as it's doubled, it looks like there is a huge increase. So again, an important point is absolute risk attributable to HRT are very, very small, less than 0.5, less than 1%, and the benefits far outweigh that risk for majority of women.
Yeah. What sort of like, because we also have to look at that risk in context with other risk factors as well. So I still do, but up until now, I was very much using the infographic, which is in the website Women's Health Concern, which we all use, and it kind of gives the risk of the background population risk, and then the risk of HRT, then the risk of things like obesity, alcohol. So that's also quite useful, isn't it, when we're sort of looking at that risk and conveying that information. But I guess my question to you is, when you are having that conversation with women, what sort of aids and tools do you use that could help, you know, primary care physicians and other sort of individuals who are seeing women in their sort of day-to-day clinic? Because obviously not everyone has that luxury of being able to see a menopause specialist or, you know, a gynecologist, for instance. So how could clinicians be able to aid women in that decision-making process using certain tools?
You're right. So I think there are two tools which generally get used in most clinics I do. For example, the one that you referred to, the Women's Health Concern infographic, by far that would be the best one to use. So if a woman comes in and says, I'm starting HRT now, I've had menopause after 45, what is my risk of breast cancer? I think that is the single most useful document, because you see the background risk, the risk with HRT, contraception, obesity or high BMI, smoking, alcohol. You can kind of give a perspective as to the risk being not so high as it's made out in the general media. If you want specifics in terms of any cancer risk based on family history, then there's something called as CanRisk, which is one of the tools that's often recommended by many institutions here. And CanRisk is basically going to take your family history, your own history in terms of cancers. It's going to take certain variables like histology if you've had cancer in the past. That's a step ahead, which will give you kind of a bespoke or a unique risk to you. But there are many other useful calculators, online calculators, which do exist. So there may be very specific calculators based on populations in specific countries, which could be used. Now, NICE guidelines with their latest guideline last year also produced useful infographics. The only problem with them is NICE often goes by observational studies or observational data. So they haven't really given the same recommendations or the stats as the British Menopause Society or the Women's Health Concern has given us. They use slightly higher risk estimate using observational studies, but nevertheless, they still show that the absolute risk, either with estrogen only or with estrogen progesterone, are very small. So for many GPs in UK, or even those who are outside UK, if you can access NICE documents, they're free to access on the website. You again get very nice pictures showing you 1,000 individuals and how many of those will have an increased risk. So you can use the one that best suits your local practice.
So the decision aids have certainly been useful, but I agree
100%.
that I think the BMS had their own kind of statement on the use of data. But also on a side topic, a little bit kind of nuanced, is that they didn't really, because we know from the Women's Health Initiative and the Million Women Study, which came out years ago, and then obviously HRT had a bit of bad press, but now we've got some products that are safer, for example, the transdermal estradiol products, as well as the body identical progesterone. We don't have enough data to give us more information about the newer progesterone products like micronized progesterone and dihydrogesterone. And I don't know if NICE also included that as part of their sort of guidance as well. I think one particular study that we all know about is that French
French
E3N
cohort
cohort study. Yeah. So that obviously has given us a little bit more hope in terms of, okay,
confidence.
yeah, confidence in prescribing, especially now that we're seeing more and more women are on these products. But what would you say about what do we have in terms of, studies and data with these particular products?
So as you rightly alluded to, we don't have much. We can only go by the observational studies, because the good thing about WHI randomized trial, it had lots of flaws, lots of problems, lots of negative publicity for HRT. But at the end of the day, it was a randomized controlled, well carried out trial. And it had a synthetic progestogen, the medroxyprogesterone acetate combined with conjugated estrogen. And those risk sort of estimates that we get from Women's Health Concern or RCT are based on those products. So we know that even if you use a synthetic progestogen like norethistérone or Provera or levonorgestrel, the risk you are looking at is about that 4 to 5 extra individuals per 1,000 for 5 years. And then it will double maybe in the next 5 years. And that risk is the maximum in terms of the synthetic progestogen.
Yeah.
Now, if you then use the modern ones, so you combine estrogen, which is estradiol, with dydrogesterone, the body similar, or the micronized progesterone, which is the body identical progestogen, then of course your risk will be likely smaller than that. Can we say that with 100% confidence? No, not yet, because it's observational data. These figures haven't been really coming through lots of RCT data, which is gold standard. But the observational studies are there. There are big studies, like the Lancet meta-analysis from Vingradova, the big paper that came in 2019. And there are many others, like the French cohort study. If you look at all those individual observational studies, you do get the feel and the confidence that these two, the dydrogesterone and the natural progesterone, have an even lower risk than the maximum risk with the synthetic ones. So you could say maybe 1 to 2 in 1,000 rather than 4 to 5 in 1,000.
Yeah.
Or even some studies suggested no risk for first 5 years with micronized progesterone, and then a small increase in risk, maybe 1 to 2 for the next 5 years.
Okay.
So all we can say is, if you have worry about breast cancer, you have family history, you want to choose the safest preparation, then you will use these two progestogens along with estradiol. But if you don't have particular risk factors, and sometimes then the levonorgestrel or Provera might be the better one if you have bleeding issues, then go for the synthetic progestogen.
Yeah, exactly. And we've obviously got to then balance against the risk of endometrial cancer, etc. And just a little kind of, again, a bit more nuance as well, but there's all these other caveats, continuous versus sequential, where the risk changes. And I'm sure that's not a huge change in risk, but also in terms of, on a practical level, when I see women who are also on, let's say, micronized progesterone and estradiol, but at the same time are taking an extra progestogen for contraceptive reasons, for instance. So how does risk change when we're kind of looking at these individual scenarios? Sorry, that's very specific.
No, it's a very good question. And the answer there is we don't know a lot. Because when we combine progestogens, we haven't done studies long enough in women combining 2 or 3 different types of progestogens. So they're taking their estradiol, which is good. But let's say you have a progesterone-only pill, you have Cerazette, or you have some other desogestrel or norethistérone pill, and on top you're taking micronized progesterone. Does it add? Do the individual risks add up? Or as a whole, the risk remains the same? Or actually having 2 progestogen, does the risk multiply and become something bigger? How long? Is it 1 year, 5 years, 10 years until that happens? And then what happens if you go for off-license dose? For example, we often say if you're bleeding on 100 milligram progesterone, take 200 every day. That's the sort of easy answer to stop bleeding. But 200 every day is an off-license dose. It's not commonly studied that way in most of the studies. So in protecting endometrium, we don't know what the extra risk is for the breast.
Yeah.
So there are so many unanswered questions there. We
Mm.
go as we go along to try and protect the endometrium, provide contraception, but it's always important, as you and I always say, counseling women, that there are some things we don't know. We think this will not be a problem, but actually try to keep on the lowest dose and the lowest combination that you need for your menopause symptoms. That's
Yeah.
the way to go. Yeah.
Yeah. And of course, we do know as well that the risk of breast cancer is also not sort of dose dependent, but more duration dependent as well. So to keep as long as they need to, but the shortest duration would, of course, reduce that risk of breast cancer as well.
Yes, I
Yeah.
think as we always say, HRT is the treatment for menopause symptoms. It's for quality of life. It
Hmm.
has some benefits for bone and heart, but
Yeah.
you really want to take it as long as your quality of life is affected. There's no arbitrary limit. If you want to come off it and you don't need it, you don't get rebound symptoms, then come off it, because every medication has benefits and risk. And if you've come out of a transition to the extent that you're not experiencing symptoms,
Yeah.
then don't take it,
Yeah.
because you have other lifestyle non-hormonal interventions for bone, for heart, and other systems.
Exactly. Yeah, no, that's a perfect way to put it, actually. And moving on to the, because you mentioned a little bit about, women who've got a family history. Again, there's no cumulative risk. So when a woman's risk is on a certain level, HRT wouldn't really increase that risk further, as we know. So this is a very common scenario that we face, actually. We know how common breast cancer is now. And a lot of women have family histories of breast cancer. So how do we address that conversation of when they want to start HRT, or they're considering it or continuing it, when they've got a family history, or even the other scenario for us is if there's a suspicious lump, for instance, how then do we go about the management of menopause?
So I think if certainly somebody has a lump or discharge, something unusual they're finding on their breast, I wouldn't rush with HRT. The first thing is to get the diagnosis, what lump it is. It's benign, it's fibroadenoma, something else, then that's fine. But as long as the diagnosis of cancer has been ruled out, then you come to the discussion about HRT.
Yeah.
Now, if you have family history, you have certain risk factors in your life which would increase your baseline risk of breast cancer, then of course the discussion is you already have a slightly increased baseline risk. Now, risk depends on age. Let's say for a 50, 60-year-old, it's about 1 in 20 or 5%. Or let's say lifetime risk is about 12, 13% on an average for every woman. 1 in 8 women will get a diagnosis of breast cancer in the UK. So if you look at those sort of baseline risks, let's say 12, 13% lifetime, then on top of that, the HRT will bring you about 0.5 to 1% extra.
Yeah.
That's for somebody who doesn't have risk factors, which are obvious, like family history or genes. Now, if you have family history, your background risk from 12 to 13% or 5% at 60 will usually go about a few percent more already.
Yeah.
And then you're adding that 0.5 to 1% on top of that. So you balance, how are my symptoms? How are they affecting me day to day? And I'm going to get that 1% extra risk on my already elevated risk. Is it worth considering that balance? And many women will find it is still worth taking HRT for their quality bones heart. At 1% risk is not adding much to their already elevated risk. And that's sort of argument that you will often have for going for HRT. While some women may say, my symptoms are not good, but I can manage. I don't want to take that 0.5 to 1% extra risk because I already have a slightly higher risk with family history. I will go for everything non-HRT before I go for it.
Okay. And if for those high-risk women, let's say there's a certain cohort of women who we sometimes do refer to for genetic counseling. If they are wanting to start HRT, or there's a question of whether they should now or once they've had that sort of testing or conversation with the genetic counselor, how do we then approach that scenario in clinical practice? Do we sort of wait for that sort of process to be sort of solved before we start HRT, or can we do that simultaneously?
If there are multiple members in the family, let's say there are multiple members which we think that genetic testing will be useful, there is a high likelihood of finding a gene.
Yeah.
Then, of course, if the patient can wait, they have symptoms, but they're waiting to see what the outcome of testing is. Do they have a BRCA gene? Are they advised about mastectomy in future? Are they advised about having BSO or risk-reducing surgery? If they want to wait for that outcome and they're happy to do it, fine. You can complete that diagnostic pathway, see if they have an obvious gene, and then decide when to start HRT. But many patients will say, actually, this will take months. I'm really suffering. I want to go with HRT. I offer HRT in that situation. I say, start doing the testing, because if you pick up a gene, then we might have to rethink our strategy as to what we do with HRT. But it's not that you can't start now. If the symptoms are not good, start HRT. Let's go for the lowest effective dose, safest type of estrogen, progesterone. Have your genetic testing, and we'll see what the outcome is.
Yeah, I think that's a good way to sort of counsel women, because also it's not sort of going to be changing at such a rapid pace anyway. So
Correct.
that's obviously reassuring for women. Okay. And then moving on to a slightly more controversial topic is women who've had a history of breast cancer. And of course, many of them get affected by menopause from their treatments, chemotherapy, hormone treatment, surgery. And sometimes that menopause, and in fact, not sometimes, in a lot of cases, it's quite troubling. It's more distressing than the actual treatments that they've gone through. Now, there's been a new consensus. I'm not sure if you've read that recently. I think it's a GP-led consensus with some experts who've sort of shed a little bit of light into the different types of breast cancers, the estrogen receptor positive, negative, ductal carcinoma, and talking in those sort of, talking within these categories. Now, we know that estrogen receptor positive breast cancer, I think HRT is, in general, the general consensus is it's contraindicated, unless obviously in very, very significant cases. But what about the other cancers? Like, what would you say in terms of, let's say a woman is very sort of, quality of life is very low and she wants to take HRT. What's your take on that? And I guess we can also look into the alternatives that women will have as well.
Of course. I think as a general rule, one must say, any breast pathology, even for the ductal in situs or the others or any cancer, HRT is contraindicated. Let's say that's the definite standard guidance. And that's because no one wants their cancer to grow or come back. And so HRT should not be ideally used as a first-line option for anybody with history of in situ or diagnosed cancer there. But there are, of course, then small subheadings there. For example, if you have receptor negative tumor, a triple receptor negative tumor, if you have a hormone receptor positive tumor, you've gone through the treatment, you're all clear at 5 years, completed your adjuvant therapy. You've got in situ or ductal in situ, and then it's often treated as not malignancy, sort of pre-malignant or benign. And then again, do you take HRT in that situation? So those are sort of small nuances that come up. The simplest sort of advice there, not to complicate things, would be go by what the patient prefers and how she is, because she will be the one who will be making that decision along with you. Even when you read the treatment of early breast cancer, nice guidelines, the breast guidelines, there is a caveat there. HRT should not be advised as a menopause treatment except in exceptional circumstances. So that rule is applicable to all these stages, whether it's DCIS, cancer. You will have those occasional women who are unlucky that when they go through menopause, having had breast pathology, their life turns upside down. They have terrible symptoms. They don't even feel like living with all that's going on with them. And I have had such patients myself. I'm sure you will see many of them, where they've tried everything non-hormonal first, whether it's vaginal, whether it's systemic, various forms of treatments, therapies, alternative treatments. And they've come to a point where they say, I would rather live well rather than just suffer this for the rest of my life. And I'm able to take that risk with a shared decision with you, but I understand that traditionally old studies have shown increased risk of recurrence of breast cancer. They're not with modern HRT. they have their problems. The studies are not accurately reflecting the hormones we use today, but nevertheless, the evidence goes to say there is an increased risk of recurrence, but I'm ready to take that small percentage increase because I cannot function like this. At that point, HRT would be an option on the table.
Yeah.
But my worry is sometimes that's generalized. Not every patient without counseling shouldn't be offered HRT as an option because we want to keep it last only when it's really required. Equally, if a woman is really suffering from menopause and she's in a position where she can understand the risk and make a shared decision with you, may have completed a fair bit of treatment, then you don't have to necessarily deny it when she's ready to have that decision with you. That balance has to be struck appropriately.
Yes, and of course, as primary care physicians, I would always advise all my sort of
Yes,
fellow colleagues
correct,
to always
correct,
kind of have a shared care basis going here to make sure that the oncologists are all kind of aware of what's going on as well
correct,
when it
correct.
comes to
I
it.
think they are a very important part of this decision
Yeah.
making. And also equally important is, I would say, always do these decisions in specialist clinics because this is a really specialist area when you consider HRT on background of breast pathology. And it's best to do it in the end tertiary and clinic with all the specialists involved with direct access to oncology.
Yes, so you would advise that all kind of complex cases should be
Of
under
course,
specialist clinics for
absolutely.
sure. Yeah, okay. And then for women whom, we know that there are non-hormonal treatment options. Would you be able to just kind of shed a little bit of light into what we've got at the moment currently, what's kind of the top sort of treatments that are that are effective and are safe to take, and then some in the horizon that we know of as well?
Yeah. So the biggest breakthrough, in fact, has been the NK3 receptor antagonist. You have the fezolinetant, now you have the elinzanetant coming. And those sort of are very useful for vasomotor symptoms, flushes, sweats, sleep. And they reduce about 50-60% of them, of these vasomotor symptoms. That's a big sort of advantage, especially if you're going through treatment, soon after treatment, and you've come to a point where the menopause symptoms are now really the most important bit to tackle. That would be a good time to consider an NK3 receptor. They don't have any major side effects, except that you need the liver function testing. If you're sensitive or your liver enzymes go up, you can't have the medication.
Yes.
The other than that, you have the traditional SSRI, SNRI, antidepressant medication. They've got a bad name recently. People try to demonize these drugs, but actually they have their role. Because for women who may not be able to take HRT, are worried about the small risk that it does bring in, the SSRIs will take care of some flushes, sweats, make you sleep better, take away anxiety, and often work very well when in a small dose, in a particularly niche group where they can't access HRT.
Yeah, yeah.
And then there are many others, the gabapentin, pregabalin, clonidine. We don't use them because they've got significant side effects. But for particular individuals, maybe the profile of the drug will suit. So you have the occasional person where these mainstream drugs may not work, and the typical second line drugs may be better.
Yes.
And then, of course, you've done posts on the CBT, some of the cognitive behavioral therapy techniques. You have alternative treatments like acupuncture. Not a lot of data there for acupuncture, but still some women find it useful.
Yeah.
And as long as it doesn't cause harm, I think every individual will follow certain lifestyle and alternative treatments to keep themselves going.
And it's okay for them to be on all of these in combination, because obviously some of them are targeting some symptoms, others are targeting others. So I guess, here we don't have to sort of worry too much about, interactions. Although I guess with the newer neurokinin, the NK3 inhibitors, they, first of all, I guess they've not been through the final stages, particularly with, the Veoza, for instance, that's not been studied in women with breast cancer, but the elinzanetant has gone through its sort of final.
So we don't have specific data in breast cancer patients for fezolinetant, but we've kind of built up an experience now because we got the drug in the UK around early 2024.
Yeah.
And we've certainly been offering it to women post breast cancer who've finished their active treatment. And we're now at a stage almost towards the end of 2025, where women are continuing to take the medication safely. So we have built up a sort of real life clinical experience with fezolinetant. And when the elinzanetant does come in, it's just recently has been licensed, it'll be another valuable addition. So as we go along, we'll build up so much more data with these medications. And you're right, you can always combine it with few others. The SSRIs have a role, the alternative therapies, you could combine them. The only bit important to remember is some SSRIs can reduce tamoxifen efficacy. So we are going to try and avoid the specific ones.
Yes. So we'll obviously get more data, particularly with because obviously SSRIs and SNRIs have been around for a while, but the interactions between these and the newer ones, I guess that's yet to sort of come out later. But it's great that obviously we've, obviously they are offered in private clinics. So we are getting some information through that. Hopefully we'll get more. Okay, amazing. Lastly, because we've had some newer guidance on the use of vaginal estrogen, particularly the American Urology Association released some guidance on the use of vaginal estrogen for, post breast cancer treatment. And I think the one big caveat previously was the ladies, the women who were taking aromatase inhibitors. So I think they've sort of said it's safe, of course, under shared care decision making, but what's your stance on that?
I appreciate the Americans there. My stance is similar. So even sort of for many years now, we often say vaginal estrogen is fine, doesn't increase anybody's risk of breast cancer. The amount that's absorbed is so little, it's unlikely to influence risk. Of course, with the studies which were out, people said if you're on tamoxifen as endocrine therapy, safe. But if you're on aromatase inhibitors, based on one or two small studies, like the Danish study, they said maybe it may increase recurrence, stay away from it. But of course, every study can be criticized. There were flaws in that analysis as well. So we've often said, try the lubricants, the moisturizers, the alternative preparations. And if not, it is fine to consider, even with aromatase inhibitors, fine to consider vaginal estrogen. Stick to the lowest dose, perhaps a 10 microgram, or try the estriol, which is supposed to be slightly better than estradiol. Use it in not more than recommended doses. And evaluate how your symptoms go. Because actually benefits still will outweigh a small increase in risk, even if you think that the Danish study was right and the aromatase inhibitors are a problem, because you're kind of opposing their action. At the end of the day, risk will be very, very, very small, and the benefits will outweigh risk. So you can consider it as a second line option.
Yeah, and we've got lots of ultra low dose products, especially in the UK anyway. So that's been great. The final topic, and I know this is a big topic on its own, but sometimes women also inquire about testosterone. Now, we know that testosterone aromatizes into estradiol, but we don't have the data in terms of how, the risk with breast cancer, for instance. So what would you say about that?
I tend to again follow the rule that if I'm not giving somebody estrogen, I won't give them testosterone right now. And that might change in future. So if right now, if somebody comes to me and says HRT following breast cancer, and I'm not going to give them HRT or say advise against it, I will say the same for testo, because it is possible that significant aromatization happens. It converts into estrogen in the body. It does affect the breast tissue. Now, some people try and go around it by giving, say, if they're already on aromatase inhibitors, or giving an aromatase inhibitor alongside testosterone, because then you could argue if you give testosterone, the letrozole or anastrozole will block aromatase. You won't get conversion to estrogen, and that way you will only get benefits of testosterone. And that comes from a bit of work from America. There are particular clinicians in America who do work about testosterone implants or therapy alongside an aromatase inhibitor, who seem to have published some favorable results. But by and large, we don't have a lot of data on what the actual risk is if somebody goes to use testosterone after breast cancer. So again, the same rule as we would do with HRT, I use it as a last option. Go for non-hormonals. And if you're still having symptoms, you're in that exceptional criteria where you're prepared to take the risk, sometimes an unknown risk of what long-term testosterone will do. It is a shared decision in exceptional circumstances.
Yes, excellent. No, that's good to know. Because here in Dubai, I mean, there's lots of different scenarios that we also encounter. So it's always good to have that clarity based on the different products. And it's a very individualized sort of
Of
scenario.
course.
You know, every woman's different. There's no one size fits all as
Well
well.
said.
So, you know, we have to take it on an individual level. No, thank you so much. I think we've covered most grounds in terms of, you know, breast cancer risk, how to manage women who've had breast cancer treatment. Just one last question. What would your advice be for clinicians or take-home message in terms of managing women with that sort of concern about breast cancer risk in you know, particularly when it comes to that and HRT?
Yeah. So I think I'll summarize it as one, for women who have no high risk factors or no major risk for breast cancer, are going through menopause, finding it difficult, symptoms are now starting to affect them. They have benefits from bone and heart from HRT, which you can see they will probably benefit. I think explain that the risk of breast cancer with modern HRT is very, very small.
Yeah.
And so therefore for them, the HRT will be beneficial, improve their quality of life for 5, 10, 15 years, and it will have more data by the time they get to another 15 years. So benefits will far outweigh that small 0.5% risk they have of breast cancer. If they already have risk factors, then try and focus on lifestyle. Say to them, I would still give you HRT, but actually you can lower your risk by doing exercise, not drinking or limiting alcohol, not smoking, addressing your weight. Don't forget the lifestyle aspect. But if they have non-modifiable risk factor, genetic or family, again, say to them, look, you already have a slightly higher risk. So we have to be cautious with HRT. But it's not that you can't take it. Your benefits will still outweigh risk if you're having significant symptom. Best to stick to the lowest effective dose, the safest preparation. And that way, that 0.51% risk will be slightly more on top of your risk, but it's not causing you any major increase in your risk just because you have background risk factors.
Excellent.
And finally, women with diagnosis, as we talked about, HRT shouldn't be used as a first option. Keep it last, because we know that combined HRT can increase somebody's risk of cancer coming back. So unless they've tried all the non-hormonal alternatives, they've come to a point where really they're struggling. You can see that they are the one who would take that shared decision with you, accept that risk. Then HRT would be one of the last options on table, not that you completely rule it out.
Yeah, exactly. No, I think that's a really nice, simple way to hopefully help other clinicians help obviously women make that decision, because obviously the decision has to be theirs, but they need to have all the information to make that informed decision. And I really hope that this will help not only clinicians, but also patients as well, women who are struggling with these questions and concerns.
And we all hope that as research progresses, we will have more answers about the different progestogen, the combined additive risk. We might even have research that suggests how safe HRT after cancer is with the modern hormones and the typical histological types. So I think the future will be giving us more knowledge about maybe able to use HRT more often with a sort of personalized approach. But until then, we have to balance the benefits and risk. So thank you so much for having me today.
No,
My pleasure.
Thank you.